Hey, and welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer. I got my co-host, Dr. Karl and Nadolsky Jr., and we have one of our very good friends. He's also a super vegan doctor.
Super vegan.
Garth Davis. He's a doc who lifts. You lift weights.
Yeah,
right?
lift weights, man. Guns.
All right.
Oh,
There.
my God. That's pure tofu.
They're not Nadolsky guns, but they're pretty good for a 52-year-old.
Yeah, they're not bad. Yeah. So we wanted to invite Garth on here, not only because he's our buddy, and we can kind of rib him in multiple different ways, but we wanted to invite him on because he is a bariatric surgeon. We're not surgeons. We do the medicines, and surgery is a very powerful, the most powerful tool we have for obesity. So we wanted to go over the different types of surgery and a lot of the myths that are out there. Like people are always like, well, I'm going to die if, I don't want to get surgery because, it'll probably kill me. I know all these people that they regain their weight and then they have all these complications and then they die. And we'll have Dr. Garth kind of go over the centers of excellence and all that kind of data as well. So welcome, Dr. Garth.
Thanks for having me. It's good to be here, guys.
Yeah, he's a busy surgeon.
With the boys.
Just a kind of real funny thing. How we met, Garth was making... he was on Facebook. He was kind of one of these famous Facebook doctors, and he would always pop up. I'd get tagged by my friend Mark Shields. Can you believe this? He's saying protein's killing us, and so we'd troll Garth. This was 2014, I think, 2014, I believe. And so 8 years ago, we'd troll him and whatever, and then finally we would go to an obesity conference, and our friend Yoni Friedhoff, who's an obesity doctor, is like, I know Garth. He's a good guy. Let me hook you up with him. So my brother and I had a meeting with him. And ever since then, we've been very good friends. We try to meet up at the different obesity conferences.
We've got some interesting online conversations. My wife looked at one of our message things. She's like, "What is with you guys?" She's like,
is there something I need to know?
Like, this is a little homoerotic here. What's going on?
Those are my favorite conversations. So, okay, so how did you get into bariatric surgery?
Yeah, so
how was that?
I came out of training at University of Michigan and wanted to specialize in laparoscopic, so minimally invasive type surgeries done with smaller instruments. And at the time, it was 2001. There was a lot of work going on with bariatric surgery at the time. It was the first time bariatric surgery had been kind of a brutal surgery, like a big, long incision, and then you got wound infections and hernias, and it really wasn't something done in the mainstream areas of surgery. But when they started figuring you could do this minimally invasively without having to cut open the fat, which could get infected, and the muscles, which could get hernias, it started to change kind of the tide. And what was happening, it was this kind of being done by kind of private surgeons in outskirt areas. It started to be done in university-type settings and bigger medical centers with more data being collected. Around the same time, the NIH had done some preliminary look at the data and found that actually weight loss surgery was very effective and that can be done safe. And so that kind of combination got me interested. And in the beginning, it's kind of interesting, when you deal with obesity. I definitely see it from you guys. You get a certain empathy for people suffering with obesity. I think before that, you're thinking, oh, this is in their mind, or they just need to do what I do. Yeah. Just eat less, move more. You're lazy. But then when you start meeting these people and seeing what they're suffering, you realize this is a real disease process with something far more complex than the average person understands about obesity. And I started meeting these people really suffering, really desperate to lose weight. And when I saw their response from the surgery, it was like, oh my God, this surgery does, we go into medicine, you're young and you have this idealistic thing, you're going to save people's lives. You take out their gallbladder, you're not saving their life that much. Well, at that time you might be, but you do this surgery and it was really an opportunity to really, really change someone's life. And so I really got fascinated with it. And the more I did, the more patients came to me, and pretty soon my whole life kind of morphed towards weight loss surgery.
So I got a question. So, you're talking about going back when you started a little bit, and you're talking about, bariatric surgery. And of course, now we call it maybe more metabolic surgery. And we'll talk about why, because of the adiposity-based diseases that really respond so well to it, like type 2 diabetes. But also, there's a lot of different types of surgeries. And so we'll get into that and have you talk, tell people what types of surgeries are being done, what have been done. But going back to that time, what was your first type of surgery exposure? Like, what were you exposed to initially?
Right. So in the beginning, it was really just gastric bypass. I mean, there had been a lot of surgery. So it started, if you go years ago, they started with what's called a jejunal ileal bypass, which was basically you're bypassing a bunch of intestine. This had some really bad complications. Really bad intestinal malabsorption syndromes where people weren't absorbing calories. It was a really bad deal because people got really sick and it gave weight loss surgery a bad name. The switch then became to purely restrictive surgeries, banded type procedures. So there was a surgery called the vertical banded gastroplasty where they stapled on the stomach and they put a band around the stomach. And that worked well in the beginning but didn't work well over time. And then all along the time, the gastric bypass is similar to what we would do for ulcer surgery. So back in the years before we had treatments for ulcers, ulcer surgery was a big part of surgery. And they noted that when you would do an ulcer surgery and you cut out part of the stomach, people lost weight. And then they started looking at the reasoning why that would happen. And it was in the 1960s that a surgeon named Buchwald looked at his post-ulcer surgeries and noticed not only did they lose weight, but their diabetes went away. And so that kind of got us looking at the metabolic side of stuff. But when I started, it was gastric bypass. And at the time, there was a new procedure called the lap band that had come out. And so we started a bit with the lap band. That dropped off pretty quickly for me because the lap band, and we could talk about the mechanisms of action. But the problem with the lap band is, to me, it seemed like a forced bulimia. We put a band around the stomach, then we tightened it to the point that you couldn't eat. But, the thing is, you wouldn't be able to eat the kind of foods, I want people to eat, which are fruits and vegetables and beans. And that wasn't fitting through a tight tube. But what would fit would be ice cream and milkshake. Yeah. And the thing about it is the band does nothing to the physiology. It really isn't a metabolic surgery. It's not doing anything to the hormone systems. And so we saw a lot of weight regain, a lot of people struggling with the fact that they're very hungry, they just can't eat. So I then went to gastric bypass until about 2006 or 7. I was one of the first people to jump on the surgery called the sleeve gastrectomy. The sleeve gastrectomy was a whole different idea. It was the idea, if you think about it, I don't know what you guys think. I'm kind of surprised there isn't more obesity in the world. And that's, we have increasing obesity rates, but why isn't everybody obese? Because when you look at our physiology, we were designed in a time of feast or famine. And we have this big, gigantic stomach. And that stomach stretches like crazy. Like if I cut out a stomach, I could blow water in that and stretch that thing. And, you just need to see people at a buffet and you can see what that stomach does. And that was pretty good back in the days when, it was feast or famine and there was a harvest or there was a kill. You better eat as much as you can because you might not see it again. It just works against us in this world we have now. Not to mention that stomach secretes a hormone called ghrelin, which makes you very hungry. And of course we have the leptin problem where if you lose weight, you lose leptin and that creates, the real central part of your brain, to set off making you hungry and to make you adapt so that you adapt as far as energy expenditure. So the idea with the sleeve was simply to cut out that excess stomach that secretes ghrelin and that stretches so that you just have a thin stomach. And so for many years I did a sleeve and a bypass. There's another surgery called a duodenal switch, which we could talk about, which is a malabsorptive type procedure. And I started doing those for my because I see some, it's so funny because, we're in the world of social media and you see people talk about weight loss and stuff, but they're dealing with people that are not the people that we typically deal with. My typical patient's body mass index is 50. We're dealing with people that are, 300, 400, even 500 pounds. And as they got to the bigger weights, I found that you really needed an even more invasive procedure. And we started doing duodenal switch with that.
So explain the band real quick, just for those who are listening. I never recommend the band. I don't think it works that well. I've never seen it work that well. But
in general, it's fallen out of favor across the board.
Across the world.
But it was very, across the
it was a big deal
everywhere. But for a lot, it was very popular up until, several years ago.
Maybe.
And it did have a lot of benefits initially.
Yeah,
right. There was pretty good weight loss, but then there were issues with the bands slipping, right, and then weight regain. So then it turned into one of these things where it wasn't a long-term answer and complications.
Right. There's efficacy with it. Now think again. Before Mounjaro and Wegovy, we had phentermine, some of these things, you're looking about a 10% weight loss or less. The band is getting weight loss, right? From an excess weight loss standpoint, we're in the 40s. I mean, it does work with a lot of patients. The idea we'd wrap a band around the top part of the stomach. The band had a tubing that went under the skin to a little port. And I could feel the port in the office, and I could gauge how much they're eating, what their weight loss is, and either inject fluid or take out fluid, and try to get it to a nice sweet spot where they were easily filled with what they would eat. This is not working on any of the hunger hormones. In fact, in studies that were done, the ghrelin hormone, which is the hunger hormone, actually increased. So these people are hungrier; they just can't eat as much.
Now, my understanding, what people tell me is they always wanted to choose it because it was the only one that's pretty much reversible, right?
So reversible that most people get it reversed.
Kind of ironically.
You're not cutting up any anatomy or swapping things around. You're just putting a band around the stomach internally.
And that was the sales. That was the sales pitch, right?
That was the
sales pitch was that it's low complications, and the fact is, actually, I got more complications with it. I mean, low complications at the time of surgery, but like Casey was talking about, the band would slip. It was hard to get it at that. Every time you swallow, the esophagus pulls up, and it could pull the band into the wrong position. It would cause a dilation of the stomach above the band, which could then cause what we call pseudoachalasia. But what that is like you just can't swallow. Your esophagus dilates really, really large. You get reflux. And so we got a lot of complications. Vast majority of people that have had the band have had it removed. And it really isn't done much anymore. The company tries to keep it alive, but it just...
Oh, really?
Oh, yeah.
I don't know anybody I don't know any surgeons who do it anymore for all the reasons we're talking about. And that's why we wanted to bring it up, because a lot of people have probably had it done.
I know a few that do it because they're so easy to do. For a while, it was such a cash cow that, these surgeons could do I know a surgeon who did 50 a week.
Holy cow!
Wow. It was, it takes like 20 minutes to do it, but
oh my gosh!
But I don't think it's a good surgery.
That's why when we ever go to the conferences with the doctors, the non-surgeons, and then the surgeons always look like dressed to the nines. They look like they got money, whereas the scrub doctors that don't do surgery,
they don't have the money.
We barely make it.
Looking around disheveled, whereas Dr. Garth comes in looking suave.
No, actually, the money dropped out because the society in the mid-2000s, the American Society of Metabolic and Bariatric Surgery, made a huge push to get a Medicare approval for the surgery. Now, before then, it was cash. And so you could charge a lot of money. So these guys were doing bands. They would charge $5,000 a band, and they would do 50 in a week. Crazy, but once we got a coding from Medicare and the insurance has jumped on that, now basically weight loss surgery is an insurance. There's some cash, but most of it's insurance. Yeah, the big money went way out. Now the money from the surgeries does not. You're not going to see a lot of fancy dressed surgeons anymore.
Now, were you seeing, say, 20% weight loss initially, like in the Swedish obese subjects trial?
We did see that. The Swedish obesity study is a great trial, so that's probably our best. The Swedish obesity study, they did, I think they had 4,000 patients, so like 2,000 in the surgery arm and 2,000 in the medical arm, and they followed them now. I think the median follow-up was 24 years. They've got some in the 30s, so it's a really good study. Now, they weren't doing lap band as much. It was the vertical banded gastroplasty. So when you see banding in that was this old surgery. It wasn't an adjustable band. But that data is pretty good. I mean, that gives us a good idea of the longevity of surgery. I would tell you that we get a lot better weight loss than they even got in the Swedish obesity study. Of course, that study is famous for showing that it extended lifespan by about 3 years between the surgery group and the non-surgery group, though they had a cohort that they followed with it that were not overweight to begin with, and they still outlived the weight loss surgery group. So the idea with that was that the weight loss surgery helps you live longer, but not as long as someone who started off not obese.
So it's better than nothing.
Better than nothing. Well, but I also think that data is probably, there's a few things wrong with that. I mean, it wasn't really one of the surgeries that VBG was done quite a bit.
That's not really
not a good surgery.
I think we all, a lot of people think of that as a gastric sleeve, but that's not.
It is not a gastric sleeve, and it created really bad eating habits.
Okay. But for anybody and I think the most recent kind of big thing that came out of it was the New England Journal article 2 years ago on the life expectancy benefits of it. So that's kind of
so people worry. They say, I'm worried I'm going to die from the surgery. And you got to understand that being morbidly obese has an increased risk of death by quite a bit. When we look at it, there's been several studies like this. That's the longest one, but there's been a couple other looking at longevity. One in Canada at Crystal, and it showed a very dramatic increase life expectancy with weight loss surgery versus non-weight loss or just medical therapy.
So a lap band though gets somewhere around 15 to 20% weight loss, right? Is that
right?
That'd
be right. But then one of the hard parts,
but then more regain
is
right?
We use percent excess weight loss.
I know,
and we want you to change that. By the way, everyone wants you to change.
You guys got to stop.
We're changing that.
So tell people out there, because that was going to be one of my questions for you to. I think we kind of know, but let's say somebody has excess weight loss of 40%. What does that really mean?
Well, it depends.
What does that mean? What does that turn into for absolute percent weight loss?
Right. It's hard to say because it depends on how much you weigh. Right. So we use the excess weight loss, and we would predict what your excess weight was based on what you weigh versus what an insurance table was, basically. So let's say someone their ideal body weight was 100 pounds. What are they, 5 foot or 4'8", whatever. Their ideal body weight's 100 pounds. They weigh 200. Their excess weight is 100 pounds. So with a gastric bypass, we would typically see at 5 years about a 70-pound weight loss. With a band, we would see about a 40-pound weight loss. With a sleeve, we'd see about a 60-pound weight loss. That would be
So it's like twice. It's 2 times, right?
Yeah.
That's often the thing. That's what we hear. Yeah.
But it's just such a stupid. It's so stupid because
we don't like it.
Yeah. There's no ideal weight. There's no the insurance tables. But okay, all right. So lap band, nobody uses it. But if you're going to, you can expect somewhere around a year or whatever, 20% total body weight loss. And I don't know the regain, but it seems to be common.
Very
people
common.
regain.
It's hard.
Plus
it's
the
hard
complications, though. That's the thing.
The things, the problems didn't do intention. The studies didn't do intention to treat. This is kind of an important thing here. The reason the lap band got so big is there were a group of surgeons who made a lot of money off of this that published all kinds of data with unbelievable results. Now, when I'm a young guy, I believe those results. Now, as an old cynic, no matter what comes out, whether it's the Manjora data or the Wegovy, I always take it with a grain of salt until I put it into action and see what happens with my patients. I don't know. What is it in our modern world? We've kind of discounted experience, but experience says a lot. Because if you talk to an experienced weight loss surgeon early on, we would have told you lap band wasn't working. But it took years for it to actually come out that lap band wasn't working because these guys were publishing this crazy data. I don't want to say they were lying, but they were doing something to make this data.
Something was going on.
So here's something, too, we notice as medical people who look at the data. Trials are different for medicines and, people, it's obvious, right? But even procedures and devices, and the FDA has a different approval process for those, and it is a much higher bar for medicines, let's say. And so the medical therapies that you just mentioned, and we, also a plug for our previous podcasts on obesity, pathophysiology, and medications. But the medications are very well done randomized controlled trials.
They are.
Right? Whereas some of the, like you were talking about the SOS, the Swedish Obese Subjects Trial, that wasn't truly a real perfect randomized controlled trial.
We've got very few of those in the weight loss surgery.
And you can talk about the Stampede trials and all that stuff with our friends from Cleveland Clinic, but I have my issues with those too. That maybe we can get them on sometime and talk about it. But I wonder if that's part of it, and maybe there are some inappropriate incentives back in the day for
the Stampede trial is pretty good as far as what they chose to do. But again, what we're finding with weight loss surgery, like a gastric bypass, I could see gastric bypass data, the Finland group did a big study with a randomized controlled trial between sleeve and gastric bypass. And they showed an advantage to gastric bypass, which a lot of the studies will show. But their numbers were so low with weight loss compared to what I see in my patients. And what we're finding is the way you do the bypass, the way you do the sleeve makes a difference. What's really interesting now in our field is length of the roux limb versus length of the biliary pancreatic limb And
wow.
and that can make a huge difference, because what happens is the longer, this is getting kind of complex, but the longer you make some of these limbs, the more you affect the GLP-1. So when we make a longer limb and we deliver food to the intestine further down, we used to think that making a long limb was a malabsorption issue, and that's why it would tend to make people lose more weight. Now we're finding out it might be more of an incretin effect, and so that we're getting a better GLP-1 effect. So it's like we're basically setting people up to have Wegovy in their system all the time, and that might be why these work. But now we're looking at limb lengths and finding that, oh my God, the length of the limb makes a difference. So if in Finland, their biliary pancreatic limb, in other words, the limb coming from the pancreas and the liver, if that limb is, they did a great study where either they made that limb 20 centimeters or 200 centimeters, there was a 20% difference in weight loss between that and in excess weight loss between that and.
So you're saying that length matters?
Yes, it does. But size.
Well, I just got
size
fired.
of the pouch,
again.
Size of the pouch does not matter. So the pouch size doesn't matter. So there's an instance where size doesn't matter, but length does. Yeah.
Interesting. Okay. All right. So we've talked about the band, though. All right. Talk about the vertical sleeve gastrectomy.
A pretty good surgery. We had a lot of interest in the beginning because it's pretty simplistic surgery to do. We're not doing any anastomosis. In other words, we're not hooking up an intestine to the stomach. So the risks of bowel obstruction from messing with the intestines is gone. Risk of a lot of the vitamin deficiencies we might see is pretty much gone. There's a slight risk of B12 deficiency, but it's not terrible. And quite honestly, I don't see a lot of vitamin deficiencies in my sleeve patients. They do pretty well. I don't see a lot of complications in a sleeve patient. Like I might get a call 5 years after someone had a bypass for some kind of issue or problem. I don't see that with sleeve. But two things with the sleeve. We are definitely seeing weight regain in the sleeve. And it's interesting when I look at trials like the Stampede trial, the bypass did better than the sleeve, but when you look at their weight regain, it was not that bad. Now, I'll tell you, in all these trials, what you got to remember, they get follow-up rates way better than we get in practice. They are on top of those patients like crazy. Those patients get top-notch lifestyle management and things like that. So in the Stampede trial, they got, it was medical therapy plus surgery. So they still got that medical intervention in that lifestyle. And so those results tend to be a lot better than what you see in the average person who gets a sleeve. And 5 years later, they're not seeing their surgeon. Even with me, who's so big on lifestyle and getting people in, I don't have that kind of follow-up. And so what we're seeing a lot in sleeve patients is weight regain over time. You could get it with bypass and other surgeries too, but we're seeing a lot of it in sleeve.
Yeah,
well, this is why we need multidisciplinary teams. This is what we have to do better as healthcare, all these healthcare systems, because you're right. In the trials, I'm looking right now at the sleeve pass trial.
Yeah,
right. Obviously,
that's
you guys are familiar with that. And the weight loss was not that much more for the gastric bypass than the laparoscopic sleeve gastrectomy. And, we can talk, a little bit about how there's so much benefit for type 2 diabetes prevention, cardiovascular risk, et cetera. But, that sleeve's pretty darn good. And I'll tell you, almost all the surgeons that I work with and around here, they rarely do gastric bypasses.
Yeah, that's become a pretty big thing. I mean, the bypass is a more complex procedure. A lot of the surgeons that were doing lap bands exclusively didn't feel that they could then go to do a bypass, so they went to do sleeve. There are a couple issues with the sleeve. We're definitely seeing weight regain. I think it is underrepresented in the studies because when you go to the national conference, it's a big topic. And when you come to my office for clinic, the sleeve failures are lining up. Number two, and a real serious issue, is the reflux. It is, you're creating an increased pressure, right? You're decreasing that diameter of a tube. And by decreasing that diameter, you're increasing the pressure. That increase of pressure could cause problems with the lower esophageal sphincter. It could cause acid to go up in the esophagus. And we get some patients with just serious heartburn afterwards. And then I every week I'm revising the sleeve to a bypass. I did 4 last week.
Wow. That's
so in one study in Brazil, they estimated that about 1/3 of patients have very significant reflux after a sleeve, which is
wow. What about medical therapy for that?
Medical therapy can help with some, but the funny thing about this is it doesn't seem to be the acid as much as it is the bile. You could take an anti-acid, but you're getting bile reflux. Now, interesting, in that study you just quoted, the sleeve pass trial, they did note the reflux, but what they found is that there wasn't an increased risk in Barrett's esophagus, which is the beginning of getting cancer. And so maybe there's reflux, but it's not really causing any serious damage. And that's good news, though it makes me concerned. So when I'm evaluating a patient, there's a few things I look at. I feel that most people aren't getting good bypass results because they're making too short of limbs. So I get better results with my gastric bypass than I see usually in the literature because I'm following some of these new studies. And we could talk about the newest surgery called SADI. We can get to that. But limb length has become a big deal. So I think the bypass performs even better than what you see in some of this literature because I think those are old bypasses. Even like the Swedish obesity is very old bypass, but even the Stampede trial was early. I think the Stampede trial ended its patient accrual in 2014. I mean, those are still early studies. Nowadays, we're making better bypasses. If a patient is super overweight, I tend towards a gastric bypass or this new surgery called a SADI because I am seeing better weight loss in the super obese. If a patient...
What about type 2 diabetes?
Type 2 diabetes.
So what if someone... And then are you using any of those risk calculators that they've come up with a few studies where it's almost like a triage tool?
Yeah.
So if you've had diabetes for longer, if you require insulin, you're actually less likely to go into remission. So there's some thought to use a sleeve as opposed to a gastric bypass, which sounds counterintuitive. But do you guys do that? Because you know what I'm talking about.
I do,
right?
I do know what you're talking about, but I've had such good success with bypass that I just continue to use bypass. Because the one thing which is huge on the metabolic side of things when we're looking at diabetes is the limb length. And a lot of surgeons, I know bariatric surgeons that just don't go to these national meetings. They don't see the data. When I talk to them about limb length, they're doing it the same way they did it 20 years ago. Limb length in diabetes management is huge. And by making a longer limb length, and the people out there aren't going to understand what I'm talking about, but by making changes in the way that I do the surgery, I get a lot better control of diabetes than I used to. And of course, if you look at the Stampede trial, the sleeve got pretty good treatment on the diabetes. And certainly if you combine that with the GLP-1. Really. But when they were looking at their main measure that they were looking at was a A1C less than 6 and off medications. And the bypass by far did the best. And I think 30% of the people got to an A1C of 6 with no medications. That's tremendous. And that's what I see in my practice. So when it comes to diabetes...
What about limb girth?
Limb girth.
I knew that was coming. I've been waiting for that this whole time.
Okay.
Right,
okay, wait, just anecdotally, yeah. I want to jump in and say, with my online, I see a lot of, I use a lot of GLP-1s online now. I have, I don't know, almost 1,000 patients through this in the past 6 months or whatever it is. Most commonly, they're VSGs, vertical sleeve gastrectomies, that are coming to me for weight regain, and I put them on the GLP-1. I don't see as many Roux-en-Ys, but, this is a selection bias. I have no idea if it's just because these are, it's hard to know if this is truly, but what you're saying might fit with that is that the gastric bypass. And then I'd like you to explain how you actually do the vertical sleeve gastrectomy. Like you turn the stomach into like almost like a small banana type of thing.
Yeah. So, I don't, there's a lot more sleeves being done than bypass now. So you might just be seeing more sleeves because.
Right. It's just because it's more prevalent.
Yeah. There was a great trial looking at VSG with Ozempic, and it had really good results. And so it may be that you don't want to do a bypass. Instead, you want to do a sleeve with the meds. But I kind of want to cure people with the surgery, and then if I don't, then we do the meds.
Yeah, then you just add meds afterwards.
Yeah.
Why not? Why not?
We do this sleeve. So the greater curve, like the outer part of the stomach, if you look at it under a microscope, it has elastic fibers. It's the stretchy part of the stomach. It's also the part of the stomach where the ghrelin is secreted, where the cells that secrete ghrelin are the Z cells. So we take the short gastrics, which are the blood vessels, all along the greater curve of the stomach. And then we have anesthesia, put a tube down through the throat. And again, now we're talking girth. So there's been a lot of studies on the girth of that tube. And
nice.
There you go.
I had to throw that in. to get the right tube size, but we kind of have a size that we think works pretty well. You don't want it too big, you don't want it too small, just right. So we put that tube in, and then we use a special stapling device that staples on each side and then cuts in the middle. And so we can remove that stomach and we take it out through the belly button. Kind of looks like in Alien when it's coming out through the belly button.
Yeah,
we actually pull that stomach right out through the belly button. And then you're just left with almost like a banana-shaped stomach. And it's actually, the surgery takes about 40 minutes. You're in the hospital one night, back up on your feet right away. People go back to work, within a week. And it's really done a pretty good job.
And then so then explain the Roux why, because so all my rotations throughout medical school and residency, whenever I do surgery, I'm like, I don't want to see anything other than bariatric surgeries, because I just loved watching them do it. I was like, this is fascinating.
Yeah. So the Roux is more complex. So with the Roux we're not taking anything out of the body, and technically it is reversible. What we do is we put that same tube in the stomach, but we shorten it. We don't go all the way through the stomach. We shorten it so that it's just on the lesser curved side, and we staple around it. So we create a little pouch of stomach. Then we go down to the small intestine, and that's where the counting happens. So we start at the beginning of the small intestine, the ligamentotrites, and we run a certain amount down. That used to be 20 centimeters. Now we're learning that if you make that 120 centimeters, you get better weight loss and better diabetes control. But we used to make it 20 to 40 centimeters. Now I make mine kind of routinely at 100. Divide the small bowel, and then we bring the distal part up to that pouch and connect it. And then we connect the bottom part down lower. I got to draw it out.
How did they figure that? Nah, don't even worry about it. I don't even know how they figured this out. Like, because when you look at what they did, it's like, why the hell did they do that?
Yeah,
like he was saying, it was other surgeries that they
right, but it just seems it's so weird.
You should see what they're doing now.
The bariatrics,
you should see what they're doing now.
GLP data from surgeries helped develop medication. I mean, this is all part of our learning process together.
Yeah, it's amazing to me because I am in an academic setting, but I'm more of a clinical doctor, so I look at the data and then apply it. But these guys that are actually doing the research, man, these guys are brave. A lot of it comes out of places where you just couldn't do it in America, like in Brazil. They do a lot of interesting stuff. But you should see all the kinds of rearrangements of the intestines. Like they've done ileal interposition, so they cut out a piece of ileum and move it up further in the jejunum. Again, thinking that you get incretin cells in the ileum, so if we get the food to hit it earlier, they've done tubes through the mouth that go down to hit food, bypass the duodenum, so we can affect the GIP. The things that they're doing right now with trying to rearrange the intestines. So the new thing now is called a SADI, which is a single anastomosis duodenal switch. And this has to have the best data that we've got so far. And we've got a 10-year study on it now out of Spain, which is interesting because I only think of this being around over the past 3 to 4 years. This was the talk at the ASMBS this week, a few weeks ago. What it is you do the sleeve. But then you cut the duodenum just past the pylorus, just distal to the stomach. And you take that and you plug it in 250 centimeters away from the end of the small bowel. So what that does is it creates a small amount of malabsorption. Plus it gets food to those incretin cells earlier, so you get a lot of GLP-1 secretion. And by bypassing the duodenum, you also get GIP. So you basically get the effect of having Manjaro in your system, but you also have the sleeve. And it's got a few benefits. We're not seeing the bowel obstructions we see with the gastric bypass, because the way the intestines go with the gastric bypass, you can get these things called internal hernias and bowel obstructions. The real Achilles heel with the gastric bypass is that it's ulcerogenic, that you're hooking up a piece of intestine to a piece of stomach, you could get ulcers. But because you're hooking up a piece of intestine to a piece of intestine with this procedure, you're not getting ulcers. So it seems to be almost like the best of all worlds. So this has become a really sought after surgery and might be the future of weight loss surgery. I think the gastric bypass will go away, and that's good.
Are you doing this one?
I'm just starting.
Okay.
In fact, I'm going to the
You'll
world
have to keep us...
expert next week, and I'm going to spend a few days with him to watch him do it.
Look at that. You've become a student again.
Always a student, right? Always a student.
Always a student
great.
forever. For those listening, though, so the reason these studies are hard is because you get a good surgeon like Dr. Garth. How do you compare that to other surgeons? Whereas the medicine is just like straight up standardizing a medicine. You can't manufacture a sexy Dr. Garth here. Daddy Garth.
Yeah, we're trying
Daddy
really
Davis.
hard now to standardize. Like, there's been a big effort in the weight loss surgery community. Well, first of all, you mentioned earlier when you first did the introduction on centers of excellence. So centers of excellence has been huge. What we have is our American College of Surgery set up a registry. Every hospital that wants to do bariatric surgery, if they want to get insurance approval, they have to be a center of excellence. So we have to go through an approval process based on our data. We have to enter everything. I mean, every single patient I operate on gets entered into a database, and I have to see my data compared to the rest of the country. So I see what my leak rate is, 0, but what my leak rate is compared to the rest of the world. Death rate, 0, but you compare it to the rest of the world. Readmission rate.
Just want everybody to know.
Yeah, just so you know,
it's the
0.
best.
But length of stay, weight. We're now starting to look at weight loss. So you could actually go to the American College of Surgery website, and you could put the Bariatric Risk Assessment Calculator, and that's using all of that data. You could put in your demographics. Like if you have a patient, you could put in their demographics, and you could see what their estimated weight loss would be at 1 year. You could see what their risks would be at 1 year. You could see if they have diabetes, what's their risk, their percent chance of being off all medications.
Wow.
And so the Center of Excellence have started to help us standardize some of this stuff. We're working on now standardizing limb length so that instead of doing a study where we're, what's the weight loss? Oh, they had a bypass. No, they didn't just have a bypass. The roux limb was this long. The biliary pancreatic limb was this long. The pouch was this size. So there's so many variables in bariatric surgery that it's hard to just say, oh, a bypass does this,
Yep, that's really cool to hear. So what are the complication rates though? Like, so that's what everybody says. Like, I'm not doing this. It seems so dangerous. I'm like, no, they're so good now.
Nowadays, in a center of excellence, the big problem was that this used to be done in places. Like I got patients, and there are good surgeons in Mexico. Don't get me wrong, but
I always hear about Mexico.
But I have had freaking nightmares. Like people go over there, and you don't know who you're getting. You might get a great surgeon. Like I know a guy in Monterey who is a fantastic surgeon. He comes to all the ASMBS meetings. He's on top. But then I get a patient who comes to me. I had one patient. She had the surgery, spiked fevers the next day. They put her on a plane, sent her to Houston, and said, "Go to the nearest ER." And so
Good luck.
there I am dealing with their complication. So, who does the surgery is important. And it's going to be determinant of what the complications are. But if you're at a center of excellence, the risk of dying from the surgery is like really, really low, 0.2%. And keep in mind, we are operating on sick patients too, right? Really overweight, diabetic, heart disease. The complication rate is really small. In fact, we've been started to do surgery on people that are waiting for heart transplants or kidney transplants because they can't get a transplant if they're overweight. So we're starting to do weight loss surgery on these sick patients, and they do okay. The main risks are going to be the reflux in the sleeve and the ulcers and the gastric bypass. The ulcer rate is probably 5 to 10% of patients. The reflux is probably 30%, but it's easily treatable in most patients with the sleeve. There are other complications, and we do see vitamin deficiencies. I worry in gastric bypass patients about bone disorders. That has been followed quite a bit. I check PTH values in all my gastric bypass. You can't just look at calcium. So you need to know if your parathyroid gland is actually activated because your body's trying to eat your bone in order to get calcium because you're calcium deficient. We keep track of vitamin D levels. But we don't see, real serious vitamin deficiencies unless people have problems, unless they have an ulcer and they're not eating and they're not taking vitamins, they're thiamin's deficient, then you could get some issues with that. The risk of
and we do have
internal hernia, all less than.
Yeah. We have guidance, some updated guidance from 2019 from ACE, all the groups that we all belong to, the American Society of Metabolic and Bariatric Surgery, American Association of Clinical Endocrinology, Obesity Society, and there are checklists, and that includes things like, even 24-hour urine calciums to help, and bone densities. We get DEXAs on them. Do you think everyone, and I guess my first question is everyone doing a good job of getting people on the right post-op regimen? Not only just nutrition, but what do you
nutrition
recommend for,
we do terribly
post-op vitamins?
Nutrition we do terribly on. We could get to that.
Okay.
Because of course nutrition's like protein. I see all these people eating beef jerky all the time in order to be healthy. Here we go. I think we've so standardized the vitamin regimen that just about all the primary care doctors know about it. Everybody seems to be checking the right thing. At least the patients I see seem to be well cared for from that standpoint. And really, there's not a lot. Like we used to think, the surgery causes vitamin D deficiency, but then we did pre-op studies and found out these people were vitamin D deficient before they ever had surgery. So we don't see a lot of vitamin deficiencies that are the most common vitamin deficiency I see is vitamin D, which is what I see in the medical patients too.
Yeah. But it does make it worse though, or it puts you at increased risk.
It makes it worse, but
right?
I don't think it's easily. Some of the vitamin D is absorbed in the proximal small bowel, which we are bypassing. So I
mean, I get these patients, I get the referrals for the secondary hyperparathyroidism. So I have a little bit of a selection bias. So I see them. And I have patients who seem like they're not getting the calcium absorbed, which we don't really see in most people. But it definitely happens in some of the gastric bypass patients but they might be older surgeries, you know what I mean?
Yeah, it might be older surgeries.
I do personally
Certainly
see those.
The duodenal switches and those kind of things, those malabsorption surgeries. Yeah. The other thing is with the gastric bypass, remember, we've changed the acid and milieu in the this is a small stomach and it's not in there for very long. So they really cannot be doing calcium carbonate, which is the vast majority of the calcium supplementation used. Yeah. So they really ought to be on a specific bariatric vitamin. We use calcium citrate for our calcium. The B12 can be an issue. I use sublingual B12s in my patients because it just doesn't absorb as well because you're taking the B12 and you're separating it from the intrinsic factor. I hope that it joins down lower. So I do sublingual B12 in my patients, and we typically use bariatric specific vitamins. Ferrous gluconate rather than ferrous sulfate.
Okay, that's good.
So if somebody's thinking about getting bariatric surgery, what's your end recommendation?
So it depends on what.
Indications, by the way. 35 BMI plus comorbidities or 40 BMI.
Okay, so it's interesting. So in that Stampede...
I have a caveat to that.
Yeah, there's a caveat because in that Stampede trial, you'll notice that there were people getting gastric bypass surgery at the BMI of 30 because of their diabetes. And there's been the effect of diabetes has been so strong with this surgery. I really think we need to drop that. That's an old standard from the NIH, but insurance companies aren't doing that yet. But so typically you have to have a body mass index above 40 to get surgery, or between 35 and 40 with a comorbid illness, diabetes, high blood pressure, sleep apnea, fatty liver, heart disease. Those are the typical ones they look at, or reflux sometimes.
And the reason being, because we have great outcomes for them.
We have great outcomes.
Consistently. Right. I mean, whether it's these meta-analyses, if you look those up recently, that, the big actual trials, the observational data. I mean, like Cleveland Clinic just, published it's technically observational data, but, significant reductions in cardiovascular events for other people. We have the meta-analyses that show that.
Well, we've got huge meta-analyses.
And that includes fatty liver and all that stuff.
And database. The results.
But the type 2 diabetes thing, that's why there's an international joint consensus statement from several years ago now that says, hey, we really should consider this at lower BMIs, including 30, if you have type 2 diabetes and you're not getting it where it needs to be otherwise. So, it's on the spectrum of therapeutic intensity to go along with disease severity that we need to.
Yeah, I mean, the results are so dramatic. It's it really is life-changing for most patients. And I think more doctors are noticing that now. Like you guys, I think years ago, I was like, oh, this is crazy. We're not going to refer to a surgeon. But now that, we're all working in conjunction together. And the other thing, the other proof in the pudding is the insurance company, because they ain't going to pay for it if they don't think it's going to help. But they pretty much all of them pay for it now.
And the cost effectiveness data is pretty good, if I'm not mistaken. I think that's even in that 2019 guideline.
Yeah, it's actually excellent now. The insurance companies balk a bit with the cost effectiveness data because they say that you recoup the loss. Basically, you basically come out ahead at about 2 years. But most people stay on an insurance company for a year and a half.
Yeah.
So they're like,
that's the
you know,
problem.
I'm not going to get the result. But most insurance
Bunch of vultures.
they do pay for it. So
Yeah.
we don't usually have too many problems with that. It's covered by Medicare. It's covered by Medicaid. You know, it's pretty covered. But they all do kind of follow the old guidelines, which is they want you with a BMI above 40 or between 35 and 40 with comorbid illness. Those are what would set you up to get surgery. Now, choosing surgery, that's where it gets harder. I have a simple, it's all one-on-one. I don't really think this is something that's protocol. It depends a lot on patients. But I've got a simple protocol, which is to say if your BMI is above 50, I think you do better with a bypass. If you have diabetes, I think you do better with a bypass. And if you have severe reflux or heartburn going into this, then definitely better with a bypass. If you're a young, healthy, like men, especially young, healthy men, man, they do well with a sleeve. Portion size, people that are like sweets eaters do better with a bypass because you can't eat sweets after a bypass. Bypass sets up this thing called dumping syndrome because that sugar gets to the intestine so quickly, causes spike in a blood sugar, and then it drops quickly, has an osmotic force. You get cramping, your blood sugar drops, you have hypoglycemic type effects.
But that's different than dumping, though.
Well, there's two kinds of dumping.
Reactive hypoglycemia is different. That's like a late dumping.
It's a late dumping, right? So there's an early dumping, which is the osmotic force, and a late dumping. But we see that a lot.
See, I get also the people with reactive hypoglycemia.
Right.
And the basic treatment for that is, for anybody listening that might actually suffer from this, do you want to talk about it?
Yeah, we could talk about it. I've got a different treatment probably than most because a lot of people are, you got to be low carb.
Yeah, yours will be lower in protein, but higher fiber, more frequent meals, whole foods.
Higher fiber.
You know, so we can all agree on, you know, we may do a little bit more protein, but think about nuts and seeds and, you know, vegetables, high fiber, low glycemic load, lower refined processed foods, avoiding sugary drinks. A lot of it it's all the same stuff, right?
Right.
And
then you can do
we actually use some. Yeah, that's true, and we have a few other medications up our sleeves. Anybody,
but that's a kind of an interesting problem. That could be really severe. We've had people basically present like nersidioblastosis with like just severe hypoglycemia. The problem I see, Casey, is you said the right things to do. What I see doctors telling the patients is no carb, all protein. Now the problem is protein causes insulin secretion, and now you're not eating any carbs, and these people actually get worse. So what I do is a high fiber diet. I'm okay with protein, but with high fiber. And then acarbose if needed. But yeah, so sweets eaters I think do better with a bypass because they get kind of a negative reinforcement on not eating sweets. People that are portion sized people, that it's all about the portion size, then they do better with a sleeve. There are other things. If someone's like just hooked on NSAIDs, like they just have to be on an NSAID because they've got arthritis type issues, then they're going to do better with a sleeve than they are going to do with a bypass. And so there's multiple different things, got to talk with the patient. Do I feel like this patient's going to take their vitamins? Because that's more important with the bypass. These are all kind of factors you got to figure in. And I'll tell you,
very cool.
Long term, there's a couple things that I see always with poor weight loss. A return to eating junk food is, an obvious. Lack of mobility, and we could talk about that. Because generally we see in with all the stuff we've seen lately that exercise doesn't help with weight loss and all that stuff.
But in surgery patients, that's a big deal. I was thinking about it just now.
Yeah, and I really want to study this because I'll tell you that, of course, what I got to tell you is mainly anecdotal because we just haven't studied it that well. But surgery, my surgery patients that exercise definitely do better than my ones that don't. And I check on all my patients. I do in-body scans, right? So I'm looking at everybody. I'm looking at their percent fat and their metabolic rates and things like that. And I definitely see drops in metabolic rate with rapid weight loss after surgery. And those that exercise, I sent you guys one of my patients. He was phenomenal at doing his exercise, and he's been able to maintain his lean mass despite his large weight loss.
Yeah.
So
there are definitely data showing that exercise is even better for people post-op with bariatric metabolic surgery for weight loss, weight maintenance, and even metabolic. I mean, yeah. So I could try to pull them up, but I know I've had to look through those for some guideline stuff.
Yeah,
before, so I'm very confident.
It's vital. And then the other thing I see people make a huge mistake of. This is maybe the biggest mistake, and it's based a lot on just that false notion out there that you hear a lot in the social media world, is this idea of eating frequently. So I'll have a patient get a weight loss surgery and they come back to see me. So I just saw a person right now, had a sleeve many years ago, comes to see me because he's regained weight. And I'm like, what are you eating? And he's eating like every 2 hours because he thought he's supposed to eat a lot of meals. Well, that basically defeats
gotta stoke the metabolism.
Yeah, stoke the metabolism. Basically defeating.
That's a myth for anybody who's listening.
Right. Which we used to think, until all the intermittent fasting data came out. It's like, okay, I still don't want to do that, but it's all right. Can't argue with the data.
So I do a time-restricted model with my patients. I have them eat between 8 and 6, 3 meals a day, maybe 1 snack. That's it.
Yeah, that's about reasonable for probably everybody.
Yeah. So for what it's worth, I just confirmed there are a couple meta-analyses about how exercise is really good for improving body composition, and also as the endocrinologist, bone health. By the way, you talked about the concerns of bone. I mean, weight training. We are shills for weight training. This is the Docs Who Live podcast, but it is a big deal, and after surgery, maybe even more important, but really important for everybody for all these reasons. So, yeah.
Very good. Well, I think we've covered pretty much everything. We're going to have Dr. Garth back on. We're going to talk about veganism next time and his journey through the plant-based world.
Sure.
We'll give him make some eggplant jokes or whatever. I don't know.
There's so many.
Anyway, thanks for joining, Doctor. Thanks for joining, Dr. Garth. Any closing thoughts you want to say?
No.
Go find you on TikTok.
It's a complex world out there.
And
I think the most important thing to know is that these people are really suffering, and when you could provide them something that really helps. I'm happy to hang up my knife. I really am. If we come up with a solution, if the meds start working better than the surgery, great. But for the time being, these patients really need this therapy.
Yeah,
perfect.
It's a great tool and options. Yeah. So individualized therapy as always.
Right.
Very good. All right.
Thanks, guys.
That's it for this time.
Take care.
Bye.